Where is he? Okay. Yeah, please do, because I want to show him this. He didn't have this yesterday, and I want to make sure he knows I have it. Is Tammy going to do notes for us today? Miss Tammy? Chief Kaye, are you going to do notes for us today?
Yeah, I've already got already outlined right there.
Fantastic.
Just pick me up right there.
You do. I don't see people just lined up outside waiting to get in. It's not like it's standing room on the crowd, is it?
It's the weather.
What's his church?
They're all next to
Excuse
Stay for the game. What happened?
What do you mean I didn't stay for the game?
You didn't watch the whole game?
Well, I had meetings. I watched it. I had it up on my iPad. CBS Sports streamed it live. I really wished I hadn't watched it.
Just, yeah. I gotta tell you. That's a good game.
You know.
No. I hope. He didn't get picked. Is he going to be here? Is anybody see him? Okay.
Let's see.
Who are we missing? Kevin and
Who are we missing?
Jorge.
Kevin?
And Jorge. Yeah. All right, we're going to get started. Good afternoon, everybody. We're going to go ahead and get started. Appreciate y'all making it out. And we're going to try to keep things on track so that ugly clock doesn't make noise at me. I know. Shh.
You had to mention it.
Yeah, I was curious if Eric was here because I wanted him to know that I have the gavel. For those of you who were here yesterday, he didn't get it, and so I want to make sure he knows that I have that. So if y'all see him when he comes in, make sure to point that out to him. Also, it's his birthday today, so be sure to say happy birthday to him when you see him. We'll go ahead and get started on the agenda. We're going to move agenda item number 3 up to the top so that Sam Vance can get over to his booth at the exhibit hall. He's got about a 5-minute report. So, Sam, you want to come on up and do your report?
Good afternoon. My name's Sam Vance. I'm the EMS for Children Program Manager. Excuse me. I just wanted to give you a quick update on the EMS reassessment. As you all are aware, we're about halfway through our cohort here in Texas of our EMSC reassessment. You can see by the national map up here that we currently have a response rate of 45.4%. And that is, I believe, about 216 hospitals out of 478. Actually, if you hover the mouse over the state there, it should show up there. Yeah, over Texas.
It's the big one. I couldn't resist.
Yeah. All right.
How Pennsylvania did. Oh.
So they haven't started yet. They start next month.
I heard there's a void in leadership up there or something.
They start next month. Anyway, as y'all remember, this is an assessment of all of our EMS agencies, including our fire-based EMS and our first responder organizations. And the first responder organizations have been included because, as you know, they are on the scene sometimes several minutes before our ambulances get there. So it's important that they have the resources to take care of kids too. So we are also assessing them. We have sent out several letters and emails to all the agencies who are being assessed. And in addition to that, at the request of some of the RAC chairs this morning at the PEDS committee meeting, I've sent out the list of the agencies who have not completed the assessment yet to the RAC chairs and directors, as well as the PEDS committee. If any of the agency representatives are here and have not completed the assessment yet, we do have a booth over at the exhibit hall, booth 509, where we do have the ability they can fill out a hard copy or do it online. So And to keep things short and sweet for you, I just want to say thank you to all the rec chairs and directors for their help with this. Thanks to the DSHS folks. And if you all would like, I can email a list to you all too, if you'd like, of the departments who have not responded yet. And that way you can add that. Okay.
Sure.
So I will
Is
get
the
that.
link included in that for the survey?
Yes.
Okay,
I'll include the link to that.
thank you.
So, which it's pretty easy. It's emscsurveys.org.
Oh, wow.
Yeah. So, y'all have any questions?
I did have one.
Okay.
And I looked through the list that you sent out earlier this week about showing the rack chairs that were, or the racks and which agencies were in there. Do you know the weighting of first responder agencies to transport providers that they did in Texas? Or was there any pattern to it? Is it 50-50? Is it 75-25?
I'll be honest. I don't honestly know. It should be just an equal percentage
Okay.
of. So we submitted approximately 900 EMS agencies that we tried to weed them all out just down to the 911 responders. And then there's about 570 first responder organizations. So there should be an equal percentage of each. But as far as how the computer randomly chose them, I don't know. Now, and speaking of the random sample, if there are any departments that want to be included in the assessment, they're more than welcome to fill out a hard copy, and we'll include that information when everything's done,
Okay,
if they'd like.
all
You
right.
said you'll be at booth 509?
509, yeah.
All right, anything else for Sam?
Any other questions?
Does anybody in the audience have anything for Sam before we let him go? All right, thanks for being here. Appreciate your report.
All righty, thank you. And stop by and see me. So I don't be alone.
It's all about the children.
All right, at this time, we're going to go back to item number 1, and we're going to look at Chapter 15711 and the suggested changes secondary to House Bill 3556 and Senate Bill 8. Since we met in August, the committee, just for the audience's knowledge, the committee's met with stakeholder groups all over the state of Texas, and we did two things in those. We looked at this rule so that the audience could give feedback to Joe Schmieder, who was there with us in all of those, on ways to refine or make it more specific. When we met in August, we had a lot of concerns with several areas of the law or the proposed rule, and then GTAC the next day had several areas as well that they were concerned about. And so we went over it in depth, and Joe has made some changes since we were last together in August, so we'll try to highlight some of those as we look through it here. But we're just going to cover it real quick and go over that, the entire thing from top to bottom. And I'm actually trying to stall while I open it on my machine because I can't see it on that screen really well. So, but it starts off with, just to let you know about the legend. The legend has three things on it. If it's in brackets and bolded, like you see the word candidates, that means it's coming out of the rule. If it's underlined, that means it's being added to the rule. And if it's underlined and highlighted, that means that it is language specifically from the law, which means there's not a lot of wiggle room. There could be further explanatory language or more definition given to it, but it is not something, we can't change those specific wordings because they're the ones that are in the law. So you'll see that as we go through it. So the first one's pretty easy. It's adding the word applicant. If we scroll down a little bit, the next one is the same. In paragraph 5, it adds the word applicant. And when we get down to paragraph 6, this was a house cleaning measure. You see the word documents is leaving and capitalized, and the non-capitalized word documents is being put in its place. And for those of you that don't lay awake at night reading EMS rules and other legal things, that just merely, if it's capitalized like documents was, that means that it has a definition in that rule, and documents does not have a definition, so that's why they clean that up. And then we get down to paragraph F, declaration of an administrator of record. This is where we get into kind of the meat of those two laws and the changes that they required to 15711. The first one on declaration of administrator of record, and then DSHS has added in any subsequently filed declaration of a new administrator of record shall declare the following. That was due to some questions that came up both in August and in some of the early on stakeholder meetings about what happens if we change administrators of record, what happens if one leaves and another one comes on, and those type of things. So they added that to clarify that that any administrator of record. And then the administrator of record is not employed or otherwise compensated by another private for-profit emergency medical services provider. And I think Joe may be working on some additional language after the stakeholder meetings on that, because that is confusing to folks. Doesn't mean you can't work for somebody else. It just means you can't be the administrator of record for more than one for-profit provider. And so the law language is a little vague, so I think Joe may be trying to add a little clarification there. In 2, the administrator of record meets the qualifications required for an EMS certification or other healthcare professional license with a direct relationship to EMS and currently holds such certification or license issued by the state of Texas. Number 3, the administrator of record has submitted to a criminal history record check at the applicant's expense as directed in 15737, which is the part about all of us having to do background checks or criminal history record checks. And this met with a lot of positive feedback from the stakeholders around the state, because right now everybody in EMS is required to have a background check with the exception of the person who potentially owns or runs the service. And so, so that met with a lot of good approval. 4, the administrator of record has completed an initial education course approved by the department on state and federal laws and rules that affect EMS. And Joe, do you want to help with some of the rumor mill stuff on that and talk about that course real quick?
Yeah, there's been a lot of questions about what that course is, and I can honestly sit here and tell you, I don't know. It's in the developing. We want to get this part up and running. After the first year, we'll sit down, and what we're thinking is probably somewhere in the area, and just thinking of a 40-hour program, some parts online, some parts in a classroom environment. And speaking to some people around the state, one of the ideals were that we would bring in the DEA and CMS and some of these federal organizations to teach some of these programs. And as we would use it for the initial program, have them do it twice, have the initial program, then maybe later that day or that evening we make it up as set up as a Con Ed program for the already in place administrator of records. So this is still in flux. It's still being developed. But I think there's some really good concepts out there, more to follow.
All righty. The next one, 5, is the applicant will assure that its administrator of record will complete the requirement of 8 hours of annual continuing education related to state and federal laws and rules related to EMS. 6, an EMS provider that is directly operated by a governmental entity is exempt from this subparagraph, which includes a municipality, county, emergency services district, hospital, or EMS volunteer provider. And Joe, you want to talk, just because we may have people that weren't in any of our meetings, about directly operated and if they don't know what they need to do?
Sure. If you're in doubt, and there are organizations out there that believe that they are a part of government, but they really are a 501c3 or some other kind of nonprofit, if you're in doubt, contact us now so we can talk about it. And we've met with a couple organizations throughout the state here. And I'll use the one example. The one organization, when you look at the structure of the city in which they're a part of, there's a line item where the fire chief or the ambulance chief and fire chief report directly to the city manager. There's a budget in that. It's very clear that they're just like the Parks Department and the road crew and the other agencies within the city. And so when in doubt, come talk to us, just because, and the biggest question out there, I have a contract to provide EMS to a community. So that must mean I'm a part of government because I have that contract. No, you're not. You're a contractor to that. And it's no different than having a contract to provide service to a hospital, nursing home, or some other entity. So if in doubt, talk to us now. Don't wait until your license comes due 30 days before and all that kind of stuff. And we'll work with them we'll work with each organization.
All righty. And then 7 says an EMS provider that held a license on September 1, 2013, the effective date of this law, and has an administrator of record who has at least 8 years of experience providing EMS. The administrator of record is exempt from this clause, and it's clauses 2 and 4, which, if you'll remember, clause 2 is the you have to maintain an EMS or other healthcare certification, and 4 is the administrator of record has to complete the initial 40-hour course. So when we get into the stakeholder comments on other ways to prevent fraud, you'll see that there were some suggestions to maybe make that go away. But that's it on the administrator of record. As we scroll down, we get down to item K, declaration of an employed medical director. And DSHS's interpretation of that is that you have a signed agreement with a medical director. In other words, you have a relationship with a medical director. Just the word employed does not mean you have to pay them money. It just means you have to have them signed up in an agreement and have that relationship with a medical director. Senator Nelson put this in there because prior to Senate Bill 8 passing, BLS agencies did not need to have a medical director, and she wanted, and because that is, the BLS agencies is where a lion's share of the fraud was that was making the news, she wanted to make sure that there was some medical oversight in those agencies as well. So she used the word that they have to employ a medical director, and DSHS's definition is that means a relationship. You have to have a on-paper relationship with a medical director. Scroll down to U, I think, is the next one. And this is talking about, there was a part of the law that said the applicant has to show sufficient professional experience and qualifications to get their initial provider license. And a lot of us, especially in August, this section caused a lot of us a great deal of concern because there was not a lot of specificity to it. Whose judgment is sufficient professional experience and qualifications? And so, Joe, I'm going to let you kind of walk through this just real quick, just because of the concern we had in August, just outlining what you put in there and why and what the examples are.
Sure. As you remember, there was a lot of concern on each regional office could have their own opinion what is qualified or sufficient experience, professional experience. So we've changed the language. First of all, there used to be 6. There's now 5 requirements. The one that we took out was recruitment and retention. I'll explain that in a second. But what we added into all the rest is it says proof of 1-year experience, and I'll use proof of 1-year experience or educated provided by a national recognized organization and emergency medical dispatch processes. And we use the same language for dispatch, QA, quality assurance. Go down, I know I'm forgetting 2. Thank you. Oops, there we go. Medical control, and billing was the other one. So I went out online and I simply found you can take courses online in all those 4 areas. The first one just says that you and your staff have read the Texas and the federal laws on dealing with EMS. And that goes back to, and you heard me say at a lot of the town meetings, we had a provider right before the moratorium went into effect that said, I want to start an ambulance service, but can you just help me out with one simple question? What does BLS stand for? And you know, you got to say, if you don't know what BLS means, maybe you shouldn't be in the ambulance business. But so these 4 things, and when we went to all the meetings, I said, is there anything else that we're missing here that we should put in there? This bar is kind of low. We know that. And we know that going in with the understanding that as we rewrite the rules in the future, we might be tweaking these here and there. But I think this is achievable, and I think you can show this pretty much on proof, and I think it addresses the questions or the concerns on this committee, some other committees, as well as to GTAC.
All righty. Excuse me. And I think I is long overdue in the EMS rules that you actually have to sign a statement saying you've read the rules, and what a concept. V is one of the other high tension issues related with the new laws, which is about the letter of credit. And V says a copy of a letter of credit for obtaining or renewing an EMS provider license issued by a federally insured bank or savings institution in the amount of $100,000 for the initial license and for renewal of the license on the 2nd anniversary of the date, or i.e. your first renewal at year 2, in the amount of $75,000 on your 4th anniversary, in the amount of $50,000 on your 6th anniversary, and the amount of $25,000 on your 8th anniversary in business. And after that, there is no requirement for a letter of credit when you relicense. The letter of credit shall include the names of all the parties involved in the transaction, shall include the names of the persons or entity who owns the EMS provider operation and to whom the bank is issuing the letter of credit. That shall include the name of the person or entity receiving the letter of credit, and an emergency medical services provider that is directly operated by a governmental entity is exempt from this subsection. So Joe's been working and his staff has been working with a lot of folks trying to get this sorted out as far as exactly what it means. But it's a letter of credit, it's a snapshot, it's not a line of credit, it's not an irrevocable letter of credit, it's just a letter of credit that your bank says at this date and time, we'll give you this letter of credit for $100,000. And that is to meet the requirements of licensing and relicensing until your 10th anniversary in the business. For folks that this applies to that have been in business longer than 8 years, this does not apply to you. You will not have to do this, but one of the issues that came up in our visits around the state were agencies who may have changed in the last several years, where they're not at a government, they're not directly operated by a governmental entity, and maybe the volunteer group gave it over to somebody else, or it's changed hands, and DSHS made them, because the provider license is not transferable, and made them get a new provider license. So even though that agency, that 501c3 may have been in that community for 40 years, they changed and got a new provider number 6 years ago. If that's the case, this applies to them. It goes off your history with DSHS, not your history overall in the community as far as that organization has been there. So again, folks just need to really look at, if this applies to them, they need to look at their own situations, get with DSHS early, and determine whether or not, if you have questions, whether or not it applies to you. Paragraph W is the $50,000 surety bond. This caused a lot of issues in August because HHSC said that they were going to start requiring a surety bond, but they were speaking in terms of years before they would require that. And the rule at that time was really making it sound like we were going to have to show DSHS a copy of something payable to HHSC that HHSC was not going to require us to have yet. And so Joe and his staff have met with HHSC, and I'll let you explain kind of what their plan is as best you know it, so that people understand about this.
So the plan is in place right now, and it's still draft tentative, but it looks like as of January 1st, anyone renewing will have to have that $50,000 security bond if you participate in Medicaid programs. I saw a document. I was hoping to have it by today to be able to give out, but we haven't seen the final copy yet, so I'm sure it's going through the approval process. But it looks like anyone moving forward after January 1st will have to have it. And we've had discussion, but I don't know the outcome of it. It's still under review. What happens with those services that were licensed in September till January 1st? Will they have to go back and get it, or will they just catch them in 2 years, or when they come up for renewal with Medicaid? So don't buy it until you're told to buy it, because it's a 1-year life on it, and so you could just be wasting time. And something will come out in writing to everybody who participates in the program at this time.
All righty. The key part of that is the re-enrollment in Medicaid, and it sounds like, based upon what they're looking at doing, that for those of us, which is just about everybody in Texas, I think, got hit with revalidation of Medicare this last couple of months. It sounds like we'll get to do that with HHSC here in Texas, probably here in the next 12 months as well, so be on the lookout for that. And like Joe said, don't go get it until you're required to get it, because it does have a 1-year life on it. And one of the other pieces of advice, Joe, you want to give the other piece of advice as far as what you found out as far as costs, so that if they get approached by some folks who may want to make a little cash on this, they can be a little wiser purchasers?
So I'll give you the generic government answer, and then talk to Dudley privately, and he'll give you more of more details. But it really is based on your line of credit, your credit number for your organization. It should run somewhere between $250 to about $700. It should take, if you're in good standing with a good credit number, it could take as little as a couple hours to get you that. But even if you have a bad credit, it could take you up to about 4 or 5 days. So on the high side, and I talked to several bonding companies, as well as there's an insurance carrier that's also offering this bond. The most you should be paying is $700, but I can tell you that there are some people out there trying to sell it to you for $1,000+. So do your research on that, and if you want a name of a company, which I cannot give, but you might want to talk to Mr. Dudley. He could probably help you with that too.
All righty. The next one is that you have to provide documentation and evidence that the applicant or the management team has not been excluded from participating in the state Medicaid program. Actually, CMS is requiring all of us to do that on a regular basis for our agency, for all of our leadership team. There is no governmental exclusion to that. So that should be a no-brainer, but it was not written down, so now it is. And then why is the governmental entity letter of approval? And this says, the governmental entity letter of approval shall be from the governing body of the municipality in which the applicant is located and is applying to provide EMS, be from the Commissioner's Court of the county in which the applicant is located and is applying to provide EMS if the applicant is not located in a municipality. Include the attestation that the addition of another licensed EMS provider will not interfere with or adversely affect the provision of EMS by the current licensed providers in that municipality or county. Include the attestation that the addition of another licensed EMS provider will remedy an existing provider shortage that cannot be resolved through the use of the licensed EMS providers operating in the municipality or county. And include the attestation that the addition of another licensed EMS provider will not cause an oversupply of licensed EMS providers in the municipality or county. Paragraph 6Y of this subsection, which is all those things we just read, does not apply to renewal of an EMS provider license or municipality, county, emergency services district, hospital, or EMS volunteer provider organization in this state that applies for an EMS provider license. So it only applies to new people, and it only applies, and as we get down, you'll see it only applies for the first 2 years. Well, it only applies for the first 2 years because it doesn't apply to the renewal. And then paragraph 8 says an EMS provider is prohibited from expanding operations to or stationing any EMS vehicle in a municipality or county other than the municipality or county from which the provider obtained the letter of approval under this subsection until after the second anniversary of the date the provider's initial license was issued, unless the expansion or stationing occurs in connection with I, a contract awarded by another municipality or county for the provision of EMS. Notice that says municipality or county, not hospital or healthcare facility. It has to be a governmental contract that allows them to expand in their first 2 years outside of their letter of approval. An emergency response made in connection with an existing mutual aid agreement, or 3, an activation of a statewide emergency or disaster response by the department. And then paragraph 8 in its entirety does not apply to renewal of an EMS provider license or municipality, county, and the same exemptions as there were above. And then 10 says paragraph 8, which is talking about operating outside of where you got the letter of approval, does not apply to fixed or rotor wing EMS providers, which makes some sense because why would you put a rotor wing aircraft in Schertz, Texas and say you can't fly outside of Schertz, Texas? So that's that. This one also created quite a bit of discussion. And is probably one of the more powerful tools against new providers coming in. Municipalities and counties do not quite yet know what they're going to do with that, and I would encourage you guys to be having these conversations if you're with the municipalities or counties in which you operate, to help maybe provide them some guidance. I know some of them have reached out to RACs, looking for help in how they're going to measure this and what's going to be an oversupply and what's a shortage and how do we know. And so we need to make sure that we're involved in that. But the other good piece of advice we heard time and again from our state EMS director and others is, despite all this, we've got to make sure that we don't make this our problem. We're really good at making this stuff our problems. It's the problem of the person who wants to operate in the county or municipality to figure it out. The governmental entities want to know, so they do it right and they don't open themselves up to liability. But it's not our problem to solve or to help somebody prove or disprove. So just remember that. And then I think that's it, isn't it, Joe?
Yes, sir.
Okay. So that's it on the changes. We kind of went through them pretty fast, and what I'd like to do is kind of open the mic up on the floor and open it up for the committee for anybody that has any questions for Joe, any suggestions, that type of thing. This did go to DSHS Council earlier this week because of the timelines involved in the law that require it to become active and what they need to do to get the rules passed. But there is still time and a place for changes to be made, either by DSHS or stakeholders. So if you have any questions or concerns, please step up. we'd be happy. I know Joe would be happy to hear them.
And just so everybody understands, it'll be published in the Texas Registry, and then it'll be like a 30-day comment period, so that's where we can tweak this. But it did go through the approval process the other day. And I would like to publicly thank the committee and Dudley for their leadership on this. It was a great chance to get around Texas, and you guys did a fantastic job. But we cannot not forget Phil Lockwood also, who was traveling with me as we travel around the state. And I can assure you, in as many hours in the vehicle, we solved a lot of world problems. The world is a better place today because of it.
And on a couple of trips, I think you met some members of fellow state agencies. I think you had some good conversations with some DPS troopers and other folks like that.
That was with a different driver.
Oh, that wasn't with Phil. Okay.
That wasn't with Phil.
Okay. You know, so Phil was kind of the note taker. So Tammy has, Chief Cayo from Dallas Fire Rescue has kind of taken over the duties of note taker for us. And Phil came, and one of the jobs he did in all these meetings was note taking. And by the third meeting, he had wised up and he brought a digital recorder with him. You should see the look on people's faces when DSHS starts recording conversations. So there was, we assured them that it was merely for notes and that was nothing to be taken back. But there was a lot of, well, I have a friend or I know of an agency, so you know how we do that. So any questions, comments on 15711? Come on up.
Good afternoon. Chris Alexander with San Marcos, Hays County EMS. I have a friend.
You have the right to remain silent.
Actually, my service and a number of services in CATRAC are due to renew at the end of January. These are still a little bit of a moving target, especially with like the bonds and the Medicaid letter and things like that. Our application for renewal is already in. Is DISH is going to sit on that until these regulations are ironed out and we know whether we have to comply with that stuff, or will they go ahead and approve that since it's already in and this will apply to us next renewal period?
Sure. The applications are already in. You know, the letter of credit is required now. You got to name who the AOR is now. The requirements for the dispatching and all that, that's for new applicants, so it doesn't even affect you. The only thing that we're sitting on is the security bond. We're going to go ahead and process your application as we get them, like we normally would, and then we'll play catch up on that security bond when we have more definite information.
Okay, good. Thank you.
Sure. And all the regional offices are handling it the same way.
Anything else? All righty. Yes.
I got something.
Go ahead, Eddie.
Just a word from a person that only made a couple of those meetings and listening to the other committee members. Joe, thank you for making that attempt and being at every one of those meetings, seeing the great state of Texas and whatever else you did while you were out there. But thank you for showing your interest and your support.
Well, this is
That
my
seriously.
this is my home now, so.
It was just that
That was
whatever
sincere.
else you did while you were out there was kind of a humorous statement to me.
Anyway, but thank you so much.
No problem, sir. I only got threatened one time by one person who was just speaking for coming through his municipality without stopping.
See, that's how we are in Texas.
Yeah.
All righty. Well, if there's nothing else from the audience, we're going to skip over to item number 2, and we're going to look at the results of these stakeholder visits that we did. You will. I've said it a million times, but I always like to repeat it. Senate Bill 8 and House Bill 3556 were tectonic plate moving bills as far as our industry goes. And one of the things Senate Bill 8 called for was for HHSC, DSHS, and the Texas Medical Board to look at fraud in ambulance transportation from each of their own perspectives and to develop a report back to the legislature by January 1st of 2014, here in about 6 weeks. And so we went out and attempted to do that. And the DSHS role was to, let me find the exact quote here. Department of State Health Services to conduct a thorough review, including the solicitation of stakeholder input regarding the laws and policies related to the licensure of non-emergency transportation providers. And so we would go over 15711, and then we would just basically open up the floor and say, what else can be done? What are good ideas? What are bad ideas? And basically just allowed people to come up and share. A lot of frustrations were shared. A lot of good comments were made. We tried to keep the conversation on task as best as we could, but really we wanted to give the stakeholders just time with the new EMS director there, the EMS committee sitting there to say what was on their mind, and we learned a ton of information. We visited, as a committee, Houston, Harlingen, Amarillo, Dallas, Austin, and San Angelo, and then Joe and Phil made a trip out to El Paso for a RAC meeting as well. And so there was actually 7 places where we sat down and had these conversations. In those places, over 400 licensed EMS providers were present, or roughly about a third of the licensed transport agencies in the state, we believe. So the numbers were really fantastic, and we spent anywhere from 3 to 5 hours, and the EMS committee complained at every one of them because I didn't let them eat lunch. But oh, that's true. We ate lunch in Amarillo because the Amarillo boys brought lunch in, which I thought was pretty cool. But we learned a lot, and what we did is we basically just took notes at every meeting. And when it was over, we had a little working group, and we sat down with those notes and we formed them into some broad topic areas that we could fit things under. Because after visiting all these locations, even though people had different perspectives, depending upon what part of the state they were from, the issues that came up could really be lopped into 5 categories pretty easily. And so we're just going to spend time going through there. And I think we're going to start on page 3 with the Roman numeral I. So the first one, and these are kind of based upon the volume of comments that were made. It's how we ranked them from 1 to 5. And the first one was to increase the education and accountability on EMS personnel, healthcare facility personnel, i.e. hospitals and nursing homes, Medicaid managed care personnel, and patients. There was a lot of discussion everywhere we went, and even though this may be more of an HHSC topic, or more specific to them than DSHS, the stakeholders were really adamant that we needed to make sure that this made it in here. And so we'll just kind of go through each area. The first one on EMS personnel is that we need to provide education on the laws and regulations related to EMS billing practices. Medical necessity and proper use of the state's medical assistance program should be required in all initial EMS certification programs from EMT through paramedic. The second one, an EMS jurisprudence exam should be developed and implemented for all EMS certified personnel at their initial certification. So the first one says we should teach them what those rules mean so that they know what's right and what's wrong. And then after they get certified, they need to take an exam proving that they do that. There's a number of healthcare licensing that requires that already in Texas, and so it's not that big of a stretch. Third, regulations should be put into place so that EMS personnel are held accountable when they violate DSHS rules if their employing agency can prove that the violation rested upon the crew member, or if the employee knew that they were violating a rule and chose to do so anyway. This would include policies in place that require the employee to abide by the rule and a system in place to inspect and ensure that employees are following the established policies. This input was offered by many stakeholders who felt that employees who have no personal risk to their certification will not stand up or leave an employer who regularly expects them to violate DSHS rules and regulations. And then laws should be developed to provide increased whistleblower protection for EMS personnel, and laws should be developed to protect EMS providers from inappropriate whistleblower allegations. The second one for healthcare facilities, Medicaid managed care organizations, and their personnel. We put a disclaimer in there first. That EMS providers who commit fraud are responsible for their own actions, and those agencies make choices that result in violations of the law without coercion or deception. But the first bullet notwithstanding, one of the suggestions voiced over and over and over again was that to improve non-emergency ambulance transportation was to require training for nursing home and hospital personnel who request ambulances, mandate increased accountability for facilities and Medicaid managed care organizations who are a party to inappropriate ambulance transports, and the implementation of new methods to track these inappropriate transports prior to them being paid. Nursing home and hospital personnel whose job require them to arrange for non-emergency transport should be required to undergo training so that they use the proper mode of transportation when an ambulance is not required. When a healthcare facility requests an ambulance for a patient that does not meet medical necessity or requests a transport at a rate that is not legal and the agency denies their request, the facilities will then call around to other agencies until they find an ambulance to perform the transport fraudulently. The healthcare facilities should be held accountable for this practice. If a Medicaid managed care organization refuses to utilize the normal or local transport agency for an ambulance transport out of a healthcare facility due to the rate they quote and calls multiple agencies until they find one that is willing to do the transport at a rate significantly below the Medicaid fee schedule, they should be held accountable for this practice. And regulations should be enacted by DSHS Hospital Licensing, the Department of Aging and Disability Services, and the Health and Human Service Commission that requires healthcare facilities and Medicaid managed care organizations to be held accountable if they use an inappropriately licensed EMS provider, i.e. licensed below the level of care that's required for the patient, or unlicensed or expired. And when this is discovered, DSHS should be required to report that organization to their specific regulatory organization for enforcement and discipline. If an EMS provider refuses to transport a patient from a facility due to the lack of medical necessity, that refusal must be documented within a tracking system to be developed by Health and Human Services Commission that would allow other providers to discover the refusal prior to accepting the call. This HHSC refusal system would also be used for enforcement of EMS providers, healthcare facilities, and managed care organizations who basically are trying to get folks to do things that are inappropriate. That by far was probably the biggest area that we heard everywhere we went, was that EMS providers are screwing stuff up all the time, and we understand that, and it's not right. But in a lot of communities across our state where potentially there's one provider or two providers, that these agencies are getting, there's an attempt to pit them against other agencies or to pit them against folks that they will call in from outside areas. And that's just got to stop. We've got to be partners in this process going forward. So we spent a lot of time on that in this document, and we added several factors that came up across the state, but I think by far that was probably the number one area folks had issues with. And then patients, and this came up several times, that the medical assistance program, that's what Texas, that's the official name of Medicaid, by the way, in Texas, if you didn't know that. Should work with ambulance stakeholders to develop new and updated education for patients regarding the proper utilization of ambulances in the non-emergency environment. So that was the first bullet, the first item. As we go down, number 2 was increase the number, ability, and processes of DSHS EMS regulatory personnel. Second most, only to holding the other people accountable, was that we have a lot of really good rules on the books, and maybe we don't need a whole bunch of new rules. Maybe we just need enough people out there to enforce the rules that we have. It's no mystery to those of us that have been in this industry for any length of time that we don't have enough DSHS regulatory personnel, and they don't necessarily have the abilities in hand to be able to do the job that we would all like to see them do. So we added some bullets in here that we need more regulatory personnel to enforce current rules and regulations, that the EMS regulatory personnel should be dedicated to enforcing the EMS rules and regulations and not used in other regulatory strategies, and that EMS regulatory personnel should be used for investigations, inspections, licensing, regulating, and providing technical assistance to EMS providers, first responders, and education providers. And we said DSHS should develop a discipline manual so that all EMS providers and personnel will understand how the discipline and regulatory process works for both agencies and individuals. Another one that came up a couple of times, and it's something the committee had been working on off and on, and we actually put it in our rule recommendations a couple of years ago, was to develop a process to utilize EMS stakeholders in the regulatory and enforcement process, kind of like a peer involvement process in that regulatory and discipline process. DSHS should task GTAC with developing a deadly sin list of EMS provider rule violations. You know, in the license, the certification rules and regulations, there is a deadly sin list. If you commit any of those 7G crimes, murder, aggravated murder, rape, anything involving a child, you can't be certified in Texas. We said we need to develop a very similar list of EMS regulations, and if an EMS provider violates one or more of those, if they get to maintain their license, that their licensing reverts back to all the requirements placed on new applicants as a result of House Bill 3556 and Senate Bill 8. And the reversion back to new applicant status would apply to all providers regardless of their business type or longevity in the industry. So basically, some of us are grandfathered out of that or exempted out of that, but if we screw up big, we should be required to go back and go through that. If an EMS provider has multiple enforcement actions in a specific amount of time, their provider license should be revoked, or the provider should be required to revert back to to all the requirements placed on new applicants as a result of 3556 and Senate Bill 8. Then DSHS should work with GTAC, RACs, and EMS stakeholders to find appropriate ways to require higher levels of participation with RACs, EMTFs, and other regional organizations, not just the 911 providers. It was felt by folks all over the state that the more you got involved in your region, the more peer pressure and the more ability there was to help steer providers away from doing things inappropriately. And so we thought there was value in being involved regionally. With additional regulatory personnel, DSHS should implement mandatory unannounced visits to new providers within their first 6 months of operation. With additional personnel, they should initiate routine blitz inspections where they inspect a majority of providers for critical patient care equipment, such as oxygen, suction, defibrillators, monitors, et cetera. And Joe talked about some things they did in Pennsylvania, and that really hit a bell and really sounded like an excellent idea to a number of providers across the state. When they submit their initial license packet, they should be given only 2 additional attempts to submit any missing or incorrect pieces of that license packet. And if it can't be done in these 2 additional attempts, their application process and fees are forfeited and the applicant has to begin the process again. DSHS should put timelines on that as well, and if they can't meet the timelines, their process is forfeited with their fees and they have to start over. And then stakeholders across the state agreed that intent cannot be regulated. If people intend to violate the law, they will, regardless of the regulations. The key is to provide more regulators with the tools to effectively and efficiently enforce the rules and regulations that are currently in place. Number 3, there should be one type of license for all ambulance providers, regardless of the primary service type. This has been discussed numerous times over the last 6 to 10 years here in Texas, is should we have a non-emergency and an emergency provider license? And although we had some good discussion on pros and cons of it in a couple of locations, as some of the locations, primarily San Angelo, I thought they were going to come up out of their chairs with pitchforks at us when we suggested that, if that was a viable option or not. Everybody agreed that there should be one type of provider license. Some of the pieces behind that, the general public does not know one ambulance from another. And a different license may impact the provider or the regulatory agency, but will not make any difference in how the agency performs and will only confuse the consumers. And if there was a desire to regulate ambulance transport by emergency and non-emergency, what definition would we use? Is it by whether they go lights and sirens to the call or not lights and sirens? Is it by the billing definition of emergency or non-emergency? Is it by the criticality of the patient in some way that we're going to define emergency versus non-emergency? Even though we use it every day, it applies to so many different facets of EMS operations that it would be hard to determine what that line in the sand was that delineated between the 2 types of license. And then a concern of a lot of stakeholders is the largest area of fraud is in the provision of non-emergency ambulance services. And so there was overwhelming consensus that if part of the industry were segregated, the focus of DSHS, especially if they don't get more regulatory staff, would still be on the emergency providers because of the perceived impact to public safety. They can't turn a blind eye to the public provider or the 911 providers to go after or the emergency providers go after the non-emergency providers. And the concern was that because of that and limited resources, that the focus on the non-emergency piece where the fraud is occurring would continue to wane, and it would drop off of even further than what it is today with limited staff. So that was some of the areas behind that. And then another thing that came up, kind of started in Dallas and carried over to some meetings after that, was that instead of saying should we delineate between emergency and non-emergency, there was some request and some thought that regulating all types of medical transport should be looked at. That includes wheelchair transport and non-medical stretcher transport. Wheelchair transport's used to move individuals who don't meet medical necessity for ambulance, but there's not any real regulation on that. And so the thought was that there needs to be, both to protect the patient as well as to protect the provider. And then the other one that's come up because of changes across the state and across the nation in healthcare, several years ago the state outlawed non-medical stretcher transport, or what was called gurney cars, They outlawed that in Texas and said if you have to go by a stretcher, you have to go in an ambulance. Well, the problem is our population's aging. There are a number of people that need to be moved, and they can't ride in a wheelchair. They got to go on a stretcher, but they don't need medical support. They're going to their doctor's appointment or their whatever else, and they're not meeting medical necessity to go by ambulance, but that's the only safe and effective means to transport them. And so there was some thought and some suggestions made that nobody has any regulatory authority over stretcher or wheelchair, and the ban is really not even being enforced because nobody has any regulatory authority over them to enforce the ban. So it was instead of that, why don't we try to bring these into DSHS's purview? We get them more people, and then we bring that in underneath their purview so that all modes of moving medically fragile people would be better regulated in Texas, and then could be properly used for the type of person that they need to be used for. Number 4 were some updates and enhancements and refinements to House Bill 3556. The exemptions to providers that are directly operated by governmental entities should be expanded to include not-for-profit corporations whose primary purpose is the provision of 911 EMS services using volunteers or a combination of paid and volunteer personnel. A lot of stakeholders, and we're out in West Texas and some of the more rural areas, they certainly understand the requirements in there for those providers, but they feel like that they were a little bit overlooked, and for the same reason that governmental providers don't need to do that, they felt that some of those requirements shouldn't apply to them. And some of them are potentially going to be a little financially difficult for them to accomplish. So there was a suggestion either to exempt the not-for-profit agencies that primarily provide 911 or to add a population number to those requirements in those 2 laws so that it would be in counties of more than 100,000 or counties of more than 50,000 people. Then those counties would have, the agencies in there would have to, but if they were less than that number, they wouldn't have to avoid impacting further the services provided in the rural areas. There was thought that the requirement that agencies only operate in their jurisdiction where they have a letter of approval from the local government entity for their first 2 years should be expanded to require this for several more years, if not permanently. And the new administrator of record requirements for an initial education course, continuing education hours, and the ability to only serve as the administrator of record for one agency should apply to all EMS providers, including governmental entities, and should not have an exemption for tenure in the industry. And that was to help increase the level of education and sophistication of EMS leadership. As laws and regulations continue to increase, there should be a tie between compliance with DSHS regulations to incentives in the state's medical assistance program, the Medicaid managed care program, and the child health plan program. In other words, if you're following the rules, you should maybe get a few more pennies in those payments or a few more dollars in those payments because you are an above board appropriate operating provider. And so you either give them more or you take stuff away from the folks who are doing it wrong. So if there's a financial incentive to follow the rules. Provide an up-to-date listing of administrators of record for all agencies that is readily available on the website so that when folks see new operators, and if they know that they're not licensed to operate in their community, they can call that administrator of record, or they can call DSHS and report them. And that DSHS should make sure that they are in the approval business of all providers of administrator of record continuing education so that it stays focused in the right areas as intended by the laws. And then lastly, Section 5 was to increase the requirements on some legitimate business practices. The first one was to require all providers to supply proof of ownership or lease of a legitimate place of business in their licensing packet. And it needs to be the same as the agency's primary place of business. And this helps prevent some issues they had in some communities where they showed up to do a site inspection and it was a mobile mini storage unit in the middle of a vacant field. And it was not a place to do business. And a lot of stakeholders felt that the rules should say that there should be only one EMS provider at one specific address. You couldn't have 2 or 3 licenses hanging out at one address. And then require providers not only to show they have a place to do business, and not only show that they own or lease their trucks, but they should show that they own or lease all of their capital equipment needed for the level of operation that they're getting licensed at. So if they're going to be a BLS operation, they need to show that they own AEDs and stretchers. If they're going to be in MICU, they need to show they own an EKG monitor and stretchers and suction units and all the things that cost whatever level we wanted to set that at, but they need to show that they own those things. So when DSHS shows up and they look at my new service and I got an AED there and they walk out and I get it in my car and I drive it back to Brian and say, thanks for letting me use this today, and I never have an AED on my truck again. Right now, nobody's checking to see if they even own that equipment, and so that needs to be a part of the licensing packet. And then develop a 5-year plan to require all EMS providers to have electronic patient care reports that integrate into their state EMS data registry. The 5-year number was just something we pulled out of the air. Please don't get hung up on that. It was really going to be a medium-range plan, but the work group felt we needed to put a number there. And so that's why that 5-year number came out there. But the stakeholders felt that those who aren't in electronic charting should be pushed into electronic charting. One, it speeds up everything about the processing of that chart, but secondly, it makes it a lot easier to look at data and to see trends and to be able to track fraud as it's developing and not months or years after it's in place. So anyway, that's it for the report. I appreciate y'all's indulgence as we kind of dug through that. I also want to iterate the thanks that you heard after the last item. I'd like to thank the committee for their work on this. 6 sites for us, 7 sites total. I'd like to thank Joe Joe and Phil for their hard work in being at every one of these, and just the amount of stuff that we got to do. Especially Tammy, who took notes at every one of them, and complained the loudest about lunch, but she did take the notes. So you see, you kind of get a trade-off there. If you're gonna do work, you get to complain louder. But
process for just a second.
you bet.
I think that I want everybody to understand the process that we went through. This wasn't we made a list. Am I on? This wasn't that we made a list, took the list out, threw it out there on the table, and said, "What do you guys think?" What was interesting was that we didn't provide each location we went to with a list of notes from the last place that we were at. Some of the things are different in different orders based on the region of the state, but every region in the state echoed every one of these things in different orders, but it was the same thing. And it was interesting to see that we didn't prompt them to do this. They just did this when we started asking the questions, and they started answering, coming up with these ideas. So I wanted to make sure that everybody understood that this wasn't that we took this out. We made a list. Brian and Dudley and Cool Guys Animals made a list and took it out there and got everybody to vote on it. That's not how it worked. We went out there with a blank piece of paper and asked them to give us the items that they thought were most important to them. So I just want to make sure that was clear.
All righty. Anything from the committee about this report? Any questions, concerns, thoughts? All righty. Audience. Thoughts, feelings, questions? Really? Hello. Norman, hello.
You just covered it so thoroughly.
Yeah, I put everybody asleep. See, that was my strategy. I'll just read through this report, and then they'll all fall asleep. Nobody will have anything bad to say. Yes, there was a technological issue with the website. They were supposed to be up as documents for the meeting. It'll be there as soon as the ones and zeros all line up appropriately. It'll slide in there. I did send it yesterday when I learned about that to GTAC as well as the EMS Education Medical Directors Committees in total. But yes, it will be available on the website. It's currently in draft form. One of the things that we need to do before we get out of here today is accept it if we want to do that, so that we can deliver the final product to GTAC tomorrow night for their discussion. So,
There's no comments from out there. I'll make a motion.
any comments from the room? Man, really?
There we go.
Oh, all right. Come on, Doc. Okay.
One agency is called to do an inappropriate transfer. What do we, I know we don't have anything now, but what is envisioned as the process so that all other agencies who would be called would have time to get that information before the call comes in? Because they're going to hang up the phone and pick up the phone and you will not have any time to know that I know of. And what is thought about, how did they did any of the stakeholders talk about how that would work?
Yeah, actually, it came both ways. One, that maybe the facility should be responsible for any of that, or the provider who turned it down should be responsible. Where the idea came from was a lot of the RACs in the state a few years ago, after a few too many of our medical friends met an untimely end. They said one of the issues that is causing these accidents is a practice that the air medical industry called helicopter shopping. So Schertz EMS calls for Agency A, we can't fly due to weather, we call Agency B, and we never tell Agency B that we called A. And so a lot of the RACs took up methods to make that happen. So now some RACs have places, whether it's through WebEOC or EM system or whatever else it is, that if an agency turns down a flight for weather, they get on and they put that in, so that, and the other agency has that up. So by the time the provider has called the next agency for a helicopter, if Schertz doesn't say, yeah, we called A and they said no, they can look at this screen to see, well, provider A said they turned it down for weather, and that conversation can be had, and then B knows that, so they go into it with their eyes wide open. So the talk was to develop some type of thing, database, web page, data entry place where that information could be entered. So we deny a transport because it doesn't meet medical necessity, and the agency says, well, we'll just call somebody else. We can put that in there, so hopefully the other agency knows. And not only that, but then the payers know that somebody has said this doesn't meet medical necessity.
So within each rack, maybe would be the best.
Yeah. Or region. HHSC has regions across the state for Medicaid and stuff like that. So whatever it is, but that was the thought. It was much like that air medical piece that a lot of RACs are working on.
Sounds good.
All right, we have a motion. Do we have a second to approve? Second. Any other comment from anybody? Really? Okay, fine. All in favor of accepting this as the final report and send it to GTAC? Who seconded it? Justin did. All in favor say aye. Aye. Anybody opposed? All righty. By the way, we're not going to be meeting again until the February GTAC meeting, just so you guys know.
Good.
I love you like brothers and sisters, but come on, there's only so much time we can be together.
Dudley, I do expect a Christmas present. I spent a lot of time with you.
Yeah, okay, I'll get you a Christmas present. Don't you worry. All righty. Next, it's been on our agenda since we turned in our rule recommendations, and Joe, this will fall to you, but an update on where we are on the revisions to Chapter 157 in total?
Yeah, we haven't done anything with it. To be perfectly honest, the goal was to get through this and then start working on it. So you'll see, we'll make progress before the next meeting.
All right, good. And then, Justin, item 5, report from the work group examining the language in 157.11 and 157.13 regarding patient care issues when EMS ground and air providers are present. Have you all where are y'all at?
We submitted those questions to Jane, and I spoke with Bert, and she said that DSHS would have a response.
Yep, we'll have it for the next committee meeting. We'll have it for the meeting after this.
You'll have a response for the next, in the Air Medical Committee in Cheryl's. So if we're expecting a response, then we'll get it back.
Okay. We have on here the update from the Emergency Medical Task Force, and I neglected to have Victor come in and give that for us. And their next door, the exhibit hall is opened up, so their next door, there is an EMTF exhibit. I would encourage everybody to stop by and look at that. It appears as though we're within 6 days of dodging yet another hurricane season, but that doesn't mean that the EMTFs are not busy. They've done a lot of things during the year. They have a lot of things planned. They're going to do some joint exercises or fully functional exercises. One for the Baton Death March out in the El Paso area, and then the other one for spring break on South Padre. And so they're doing a lot of stuff. If you or your agency are not involved in your EMTF, I would encourage you to get involved. There's roles in every avenue. There's personnel roles in the MMU process. There's ambulance roles in the strike teams. There's roles in the ambulance operations. So if you or your agency are not involved in the Emergency Medical Task Force program, I would encourage you to get involved, because when game day happens, and the feces hits the rotating oscillator, as they say, you're going to want to be there. I mean, everybody always wants to go on game day. And so you need to get involved now so that when the bell gets rung, you'll be an agency that's lined up ready to go. Any updates from anybody on drug shortages or pharmaceutical compounding of drugs?
Dudley, I attended the medical directors committee meeting yesterday, and there was discussion yesterday, and I don't know if any of the medical directors are in the room, about the FDA is changing the rules or looking at adopting rules for compounding pharmaceuticals.
Well, yeah, I was there, I think, and I don't know the law, but apparently it has come down to the fact that it's, the new federal law is gonna require a patient name to be attached to each thing that's compounded. So you can't just order X numbers of units of stuff to stock all your ambulances. It has to be per patient.
So we'll carry a compounder in the back of the ambulance.
Yeah, right. We'll just,
A compounder in a bathtub.
we'll just use D10, not D50 if they don't have it.
Yeah.
We'll adapt as we have.
That would be specifically John or Jane Doe.
That's right.
Yeah. 200 units of John Doe.
That could be problematic when you're looking at epi or amiodarone or. Wait till we get to open. The shortage of epi?
They were also saying during that meeting that there's a shortage of EpiPens because they've warned all the schools to really stock up on EpiPens, and apparently, So the price, I'm sorry, not shortage, the price has gone way up on those. So if you haven't, you might want to try to get some now.
Great, so that just went out over the internet.
By the time I get to the webpage, they'll be gone. Or the price.
I do what I can.
The price will have. The price will have escalated to $350 from $180.
Check my investment.
Dudley, just to get an idea as to how large of a problem it's going to be on the issue of compounding pharmacies, just unofficially, who here has at least one medication on their units that's formulated by a compounding pharmacy? Raise your hand. I know a long time ago this was a
How many
year.
in calendar year 2013 have used medications on your trucks from a compounding pharmacy?
Okay, so this isn't a benign rule change.
Yeah, atropine was the latest one for us. All righty. Brian, item 8, Trauma Systems Committee Registry Work Group update.
Well, I know everybody's favorite topic is trauma registry. A couple of things that we're working on, and one of them, I guess the most important, is that we're working to put in the trauma center.
Microphone, you can get a little closer, you gotta be friends with it.
Yeah, I'm gonna be friends. The trauma registry group, they wanted to call it the trauma registry champion in each rack. Somebody who understood and could help hospitals or help EMS agencies in each rack. I didn't like that word. I kind of like the trauma registry strike team leader. Thought that a little more sexy sounding. We might actually get somebody to help us with that. The goal is for them to have 2 of them in each rack, one that specifically understood what hospitals and how hospitals needed to report, and one person that is on the EMS side could help EMS agencies. These are unpaid positions. Just don't you think there was a job there. The committee's also asking that any of the committees that want reports that are specific to your committee, for example, the injury committee would want data from the trauma registry, if you submit your question, they would ask that you submit not only your question, but also the data point that you feel like that would answer your questions so they can build the reports for you. And each committee is able to request that reports are run if that's what you want. One of the things that we're trying to overcome is the fact that hospitals report trauma, EMS reports trauma and medicine, and trying to drive outcomes and get outcome information from the trauma registry when the hospitals are only reporting trauma and and EMS is reporting both is something we're trying to overcome. So other than that, that's all I have for right now.
All right. Go ahead, Justin.
Question, Brian, how did they envision, or are they asking for a employee of each RAC to be in that position, or just a member? Or was there thoughts on who they were talking about in the RAC organization?
Not from the actual RAC itself. They're looking for somebody in each RAC, somebody who is, and there's a list of criteria. The list is quite long. But they're looking for somebody who understands what's going on, how the hospitals and what the hospitals have to report. I don't even understand what the hospitals have to report, but what the EMS has to report, and understands the nemesis and maybe can help some of the agencies that are having trouble getting their stuff together to report. One of the things that I'm asking for too is for a better user interface for the systems that don't have some sort of electronic EPCR type document. There's a handful of agencies out there right now that there's actually more agencies in the state of Texas that submit their data by going to the trauma registry website and inputting the call itself. There's actually more of those agencies out there than there are the agencies that use EPCR. However, there's vastly more runs that are put in by the agencies that use EPCR versus the ones that do it. So we're talking about very small services, maybe one ambulance that do maybe 3 calls a month or 3 calls a week or something along those lines. There's more of those. So we're working in ways to either make the interface easier or to come up with something with each RAC where they can gather the data in the RAC level and then push it to the state. Did I answer your question, or did I just like dance all around it and did a great job of that?
It was awful flowery, but you're good.
Outstanding.
Usually we get the Flaherty answers from Eddie, so it's kind of a shock.
It's an education.
At this time, I'm going to open the mic for general public comment. We've kind of exhausted our agenda. Anybody in the room have anything you want to share, any questions, anything we need to be working on, we're not working on? All right. It's all right. I'm glad you're coming up because, man, I'm concerned.
EpiPen is a trade name for it, and then there's EpiPen Junior. There's a new one called AUVIQ, which has a little speaker on it, and it gives you instructions on how to do it. And when it's through it, it retracts the needle back into itself, so it's safer to use for patients. I don't know that there's any prices. AUVI-Q for patients that, or maybe medics that don't use it often enough, and it shows a little picture of where to put it. You just hold it on your thigh, and then it gives you the instructions. Keep holding, eject it, now pull off. And
Hey, Joe, this is a
neat way to get epi.
This is not fair for me to ask you this question, Joe. I'm going to throw you under the bus and just. Okay, so scenario. MICU ambulance system. All I have is MICU ambulances. Why do I have to have EpiPens on the ambulance when I have Epi 1 to 1,000? I have lots of that. I have lots of.
You don't.
Okay.
Tell your friend they don't have to.
Well, no, that's what I wanted to be clear on, because
Sure.
I didn't feel like you did, but there's a thought out there that you have to have that,
Fully agree.
because it says that.
And
Okay,
the
I'm done.
legislature said everybody has to have it, or another way of giving it.
Right.
But the equivalent is very, at the far end of the language. That may be why some people are confused.
The confusion may also be that under your protocols, you might have a protocol for the EpiPen, not Epi. So then your drug list will require to carry both, and then you would be required to carry it. So you just make sure your protocol matches up on your MICU unit with what you're really doing.
Okay. Yes, ma'am.
Quickly, the compounding, that has just passed the Senate, it was passed,
Is it on? Might check, see if it's on.
It was on with Dr. It might have just died.
The battery might die.
I know they can't hear you.
all right,
There we
There you
go.
go.
there we go. The Senate passed the compounding issue, and it's called, I couldn't remember the full name, Drug Quality and Safety Act, and it's headed to Obama's desk to be signed. It was passed by the House of Representatives in September, I believe.
Okay.
And what it was to do was, when it's compounded, it has to go to a specific person, and that compounding drug will follow that person wherever they go, so they can track it. So it hasn't been signed yet, but Obama said he would sign it, President Obama. So it is something that you will have to deal with.
Joy.
It's
Already done, huh?
Yeah, you really can't compound large things and just write the prescription and then use it at that time.
Okay, thank you for that. Any other public comment? Come on, you know you want to say something.
Adjourn?
All right, so before we get out, I do want to recognize one person. Unfortunately, he couldn't be here today, but it was the EMS committee also looked for new members, and we had 4 people up for reappointment this time, I believe, and we had 1 vacancy, and so 3 of the 4 got reappointed. Lucille, Lon, and Justin got reappointed, and oh, you weren't up? Never mind then. Justin and Lon got reappointed. So I don't know why I thought you were. Anyway, so Justin and Lon got reappointed. Pardon me. I guess we had 3 or 4 or 3 up and not 4. And then Kevin DeRamus did not get reappointed, and I have a certificate and a letter here for him. He's been with us for several years and will not be reappointed this time. So our new members will be joining us in February. And unless anybody at the table wants to meet between now and February, that'll be our next meeting. All righty. Anything else from the committee? Okay. Anything else from the audience? Man, I just want y'all guys, we got to do something to get everybody stirred up. All right. In that case, we'll call the meeting over. We're adjourned. Thank y'all.